We're going to talk a little bit this afternoon about where we're going. We talked about where we are right now. We're going to talk about some future therapies, things that we have coming down the line. I don't want to embarrass Dr. Shapiro, but I want to brag on him just a little bit and so just do a journey back in time. We talked about the importance of comprehensive MS centers, about going to your local neurologist and not getting all of your needs addressed. When I came out of training in 1992, I didn't have a chance to do a fellowship. My wife was a pediatrician. She was doing Air Force payback time, so they didn't give her the option of where to go. They told her where to go. She went to Spokane, Washington. So I went from residency to join a private practitioner in Spokane, Washington. Spokane had a lot of people with multiple sclerosis. It was kind of interesting in that there was no comprehensive MS center in Spokane, Washington. You either went to Seattle or you went over to Minneapolis and you saw Randy. That's a long ways to go. You got a lot of states between Spokane and Minneapolis. And for a lot of people in Spokane, they thought that the Cascade Mountains were like some impenetrable wall that you weren't allowed to cross over that and go for your MS care. So as I started to get into working with MS, I knew what we wanted to be at the Holy Family MS Center. And so where I first met Dr. Shapiro was at one of the Jimmy Hugo programs. The Jimmy Hugo Center was one of the first comprehensive kind of wellness models. They weren't focused on drug therapy necessarily. They were focused on wellness, exercise, and things like that for MS, and really coming up with an individualized life plan for people with MS. And that's where I first met Dr. Shapiro. I then went out and spent some time with him in Minneapolis and saw everything that we've done at Holy Family and everything we do at Shepherd Center is really based upon what he's done. So thank you. Yep. So one of the things that Randy mentioned is that we have a lot of things to think about when you're looking at picking a treatment. And sometimes, in spite of everyone's best efforts, we go through this list, we pick a treatment, and it's still not right for you. And some people go through a lot of the treatments that are out there and we still are not quite getting it right. So that's why we may need things that are more effective, may hit the problem from a different angle as opposed to what we have right now. This is a busy slide, and I apologize, but this is a list of some of the things that are in the pipeline right now. We're going to spend some time talking about anti-lingo, the first option. I'm going to come back to that one. Later this year, there's a chance that the second option, daclizumab, may get approval. Daclizumab is another one of these mAb drugs, a monoclonal antibody. This is going to be a once-a-month subcutaneous injection that you would do on your own at home. So far, it looks like it's going to be fairly effective. As Randy said, we've always got to balance out the good with the potential bad, and the potential bad with daclizumab appears to be liver function issues and some autoimmune skin rashes. We need to see more information on that to get a sense of where does this fit into the food chain of what we have available right now. Ocrelizumab, we've mentioned rituximab several times, or Rituxan. Rituxan is this drug that is given every 6 months as an IV treatment. It is not FDA approved for MS, but it is something that we use, and the ocrelizumab is what was sort of developed as the new and improved version of Rituxan. And if things go the way that we hope they do, hopefully that drug's going to be approved in 2016, again, twice a year IV therapy. And because it would be FDA approved, we wouldn't have the insurance hassles that we have right now with a lot of insurance companies denying Rituxan. You've got a couple on here, the siponimod, the Ono, the finicimod. These are kind of new and improved versions of Gilenya. So Gilenya was our first pill that came out for MS. It has a very distinct mechanism. It basically locks up some of your white blood cells in the lymph nodes. It doesn't kill them, it just doesn't let them get out and circulate and cause inflammation. The problem is that the receptor that Gilenya works on is not just present within those lymph nodes and on those white blood cells. It's also present in cardiac muscle. That's why if you're on Gilenya, you know you had to be in a cardiologist's office when you did your first dose and have them watch you for 6 hours. The hope with these new versions of the drug is that they would be more specific and have fewer side effects. And then there's a sort of a derivation of Tecfidera that is being worked on also. This is a a research project that we've been involved with. This drug was originally called Tovoxin. It's called Selma now. And I call it a drug, but it's really not a drug. I think one of the themes you've heard throughout Randy's discussion and through my discussion is that MS is unique. No two cases are alike. And the toolbox for working with MS is getting bigger and bigger. And we are not smart enough yet to pick the absolute best treatment for each individual with our first attempt. Sometimes we do get it right on the first time, sometimes we don't. What if we had a customized therapy made based upon your individual MS? We're not there yet. This could be something along those lines. So Tovoxin, now Selma, is a T-cell vaccine. This was developed through some researchers at Baylor University. And the idea with Selma is we're going to isolate the myelin reactive T cells from the person with multiple sclerosis. Once we have those cells from a blood sample, they send those to a laboratory and they clone them. They make a whole bunch of them. And once you have a big population of those bad T cells, they're going to irradiate them slightly. They're not trying to kill them, they're just trying to whack them upside the head and stun them. And now you're going to give those weakened T cells back to the person with MS as a subcutaneous injection. The hope then is that the person's immune system recognizes those weakened T cells as weakened, makes an immune response to that, and now every time they pop up, your own immune system would take care of them. So in theory, you vaccinated yourself against your very own specific MS. The trials in relapsing remitting multiple sclerosis were, again, a very near miss. There was a significant reduction in the relapse rate, but it did not reach statistical significance. So scientifically, you could say well, there was something there, but it wasn't quite enough for us to say that it definitely worked. When you only looked at the people who had had significant relapses in the past year with that initial study, it did reach statistical significance. They've put that on the back burner and they've shifted their research efforts now to secondary progressive disease. So we're right in the middle of trials for Selma in secondary progressive MS. What are the limitations? Well, we don't know that it works yet. And the other thing we do know right now is that based upon the current technology, when we look for those myelin reactive T cells, we're not finding enough of them in every individual. So in our center, about 50% of the people that should be candidates for this study, we couldn't find enough of those bad T cells to make the vaccine from. The hope is as technology gets better, maybe we would need less of those myelin reactive T cells so that you could make that vaccine. So that would be a step in the direction of a custom tailored treatment to the individual. We're going to talk about three other sort of things that are a little bit outside the box. We're going to talk about bone marrow transplants, which someone mentioned earlier, and I put the cure in quotes because it has been touted as a potential cure, and there are some good things that you could see with a bone marrow transplant, but it is definitely one where you would want to think about the risk of that procedure also. Stem cells, a lot of buzz about stem cells. We'll talk a little bit about that, and then we'll talk about anti-lingo or myelin repair as one of the potential neural repair research areas. So, bone marrow transplant. If you have an autoimmune disease and your immune system is picking on something in your body that it shouldn't be picking on, in the case of multiple sclerosis, it's attacking the myelin, what if we could just give you a new immune system? Let's just start all over again. And so there are people with MS who have also had other types of cancers who have gotten a bone marrow transplant to treat their cancer, and very frequently their MS becomes fairly quiet. We mentioned our son's babysitter who had AML, got her brother's bone marrow. She's not on any MS treatments right now. The problem with those bone marrow transplants where you're receiving it from someone else is usually it's your brother or sister, or it's an unrelated matched donor. So it's not exactly you. And even though you might give the person a new immune system, you're also then always at risk for your body and that new immune system fighting with each other. So you can have what is left of your immune system try to reject your transplant, or you can have your transplant, which is a new immune system, say, you know what, that body you put me into is not where I came from. I'm going to fight you. That's called graft versus host disease. And usually with that sort of bone marrow transplant, you are on some sort of immune suppressant drug indefinitely. So again, not a walk in the park. Interesting idea. It's usually something, if you're going to get that sort of bone marrow transplant, it's sort of almost by accident because you had another health problem. What if we could give you your own bone marrow, your own immature stem cells from your bone marrow? And that's the idea behind something called autologous stem cell transplants. If you have a bone marrow transplant and the cells come from another individual, your brother, your sister, an unrelated donor, that's called allogeneic. If you get it from yourself, it's called autologous. I'm going to skip over to this. So you have to pardon the cartoons, but so basically the idea with this procedure is that you're going to go into a bone marrow transplant unit. They're going to give you things, sort of growth factors to stimulate your bone marrow to make more cells. They're going to harvest those cells by pheresis, sort of taking them out almost like a dialysis machine. They're going to set those cells aside and freeze them. That's when things are going to get a little bit tricky. Now we need to wipe out your existing bone marrow. This is called immune ablation. This is very, very high dose chemotherapy. Sometimes there's total body irradiation. Different research centers have different protocols, but usually it's high dose chemotherapy. The idea is to wipe out your existing immune system. They're then going to give you your immature cells back, your immature cells from your bone marrow, so that you could grow a fresh immune system. You've rebooted the hard drive, and now you have an immune system that doesn't have the knowledge to attack myelin. There was a paper about 3 weeks ago published in the Journal of the American Medical Association that showed fairly impressive results for this procedure. Drastic reductions in relapse rate. Some people actually had improvement in their level of functioning. We have to be, again, cautiously excited about that. Do we think that people could have less disability after this? Possibly. Do we think that this is directly repairing myelin? Probably not. My suspicion is that when you drastically shut down the inflammatory part of MS, you are probably letting people's natural healing capability maybe remyelinate somewhat. So I wouldn't think of this as a neural repair sort of process. Even in these really good centers who are doing this sort of research, there is a significant mortality rate. Right now they're saying 2.5% of people die from this procedure. In other centers, I suspect that it's probably higher. There is a point in time where you have no immune system, so every little bug that comes along could be potentially fatal. So again, it's an interesting thought. Most of the people that seem to benefit from this procedure are people with very aggressive inflammatory disease, not so much for people with progressive forms of MS. Skip over that. So what about stem cells? When we say stem cells, that means a lot of different things to different people. We just talked about autologous stem cell transplants. So that's a type of stem cell, but that's generally when most people with MS think stem cells, they're probably thinking more of something that might repair the damage rather than resetting their immune system. But that other procedure, the bone marrow transplant, is a type of adult stem cell. We have to be awfully careful out there. There are over 200 bogus stem cell clinics globally out there. And I'm sure Randy has had individuals come in and say, you know what, I'm flying down to Costa Rica, I'm going to China, I'm going to spend my $70,000, I'm getting a stem cell transplant. We don't know what they're giving you. In some of these centers, they're giving these cells, if that's what they are, intravenously. In some centers, they're putting them into the spinal fluid. The bottom line is there is legitimate stem cell research in multiple sclerosis. If you're going somewhere and they're charging you $50,000, $60,000, $70,000 to do it, it's not legitimate research. And so if you're part of a legitimate research project, it really shouldn't be costing you out of pocket. I'll just say be very cautious about going overseas for things where you're paying a big chunk of money. We've had several patients have this against everyone's advice, and I can say that the good news is no one has gotten harmed from it. The bad news is nothing good has come of it, and they're all a lot poorer for it. One of the common things that I've seen when literature is brought in is, and I think a little bell should go off in your head as a warning, is if they're claiming that they can treat everything. They can treat Parkinson's, Alzheimer's, Lou Gehrig's disease, MS, autism. That should be a warning sign that something's not right. So Generally, when we think of stem cells, we think of embryonic and adult stem cells. Embryonic stem cells, there's a lot of interest in that a while back, and it seems that it may be dying down just a little bit. Embryonic stem cells frequently come from aborted fetal tissue. These cells have the potential to become really anything in the human body. Adult stem cells may come from fat, from bone marrow, from a little bit more accessible type of tissue. Also, placental cord blood is another potential source. One of the questions that we get frequently when someone has MS and they have a family member who's about to have a baby, should we bank cord blood? I can say if as long as you're going to a reputable cord blood banking facility, we don't know what the potential uses might be for cord blood in multiple sclerosis, but there are a lot of other health conditions where you might potentially use cord blood. So I think if you can afford it, it's not a bad idea to put on the table. So when we talk about what stem cells can do, embryonic stem cells are generally felt to be totipotent, meaning they can become anything in the human body. And then you sort of become a little bit less specific, if you will, or a little bit more limited in what you can become, from pluripotent to multipotent. One of the problems with things that can become anything in the human body, like embryonic stem cells, is once you put that cell into the body, you've let the genie out of the bottle, and you have no control really over what that tissue can become. At Shepherd Center, we were doing research with embryonic stem cells in people with thoracic spinal cord lesions. Ethically, they selected individuals from across the country who were completely paraplegic. They had had a complete cord injury, and that they were going to surgically implant these embryonic stem cells into the site of that injury with the hope of regenerating tissue and improving function. The study was stopped early because in some individuals, the tissue, the embryonic stem cells, developed into something called atypical glandular tissue. It wasn't cancerous, but it wasn't normal, and it definitely should not have been in your spinal cord. And so in that individual, you actually had the potential to make that person worse if they had not already had a complete paraplegia. So that research was actually stopped. Skip over that. So what's interesting is when you look at the growth in research in mesenchymal stem cells or adult stem cells, this is just going back to 2004. There is quite a bit of research now across, this is not just specific to MS, but across multiple different health states looking at research into adult stem cells or mesenchymal stem cells. We don't know what this is going to end up. The National MS Society has really put an emphasis on a fourth box of MS care. We mentioned earlier that right now everything we do really fits into one of three boxes: treating relapses, managing symptoms, or altering the long-term course. Ideally, we would have a fourth box, and that's reversing the damage and repairing the damage. If you had asked Randy and I 10 years ago, and Randy may still feel this way, it was felt to be a pipe dream, but it seems like there's an awful lot of focus on it. Interestingly, a lot of the research dollars that have been coming to Shepherd Center in the past 10 years or so have actually been generated through the Department of Defense. When you think about spinal cord injury, you've got this wave of young men coming back from Iraq and Afghanistan with spinal cord injuries from IEDs and whatnot, and so there's a lot of interest in this sort of research. What about myelin repair? So anti-LINGO. So the story behind anti-LINGO is that we all have a population of oligodendrocytes in the brain and spinal cord. Oligodendrocytes are the cells that make myelin. And it turns out we have a savings account of oligodendrocytes sitting there not doing much. And what keeps them sort of locked up is a molecule called NOGO. NOGO does exactly that to the oligodendrocytes. It tells them to stay where they're at and not use them. As a part of that interaction, there's another molecule called LINGO that helps NOGO sort of work. What if we had an inhibitor of the inhibitor? So researchers have developed a monoclonal antibody. It's an antibody directed against LINGO, so it's called anti-LINGO. The idea is that you could inhibit that NOGO, let those oligodendrocytes come out of your savings account, potentially remyelinate, and hopefully restore function. What has been completed and reported now, at least in the media, it's not been published, so we've not had a chance to really dig into it, but it was reported to the media by Biogen IDEC that they saw some positive results about a month ago in an optic neuritis treatment trial. It was not as positive as they had hoped it would be. There was some improvement in visual function. Another thing they were looking at is actually measuring how thick your nerve fiber layer is in the back of your eye or the retina, and they were hoping that they would see that plump up and get fatter. They didn't see that in the study. So we're very hopeful. I think the two things they're probably going to look at in the phase 3 study are going to be optic neuritis and then gait dysfunction. Those are the easiest things to measure in that sort of trial. There are a lot of challenges going forward with that sort of research. You know, when Randy showed the MRIs earlier, MRI is a wonderful window into what's going on with multiple sclerosis. When you have a white spot, a white matter lesion in the brain, though, within that white matter lesion, there may be some natural remyelination that has occurred. Maybe there's not. That's one of the weaknesses of MRIs. We're not very good at telling how much repair there has been within those white spots. And so we know going forwards with this sort of neural repair research that we're not going to be able to use standard MRI as a measure of that sort of remyelination. We need some other tools, and there are some other MRI techniques that we can certainly look at. Got that. Going to finish up with a weird one, worm therapy.
Sit in the garage and take that.
Yeah, that's right. I knew Randy that was not going to fit in the garage. So there's a group out there, and I always love giving this if we're at lunchtime. So why worm therapy? It sounds kind of odd, sounds kind of disgusting. The idea here is that when you look at certain parasitic infections, so we talked about how we come to have MS, vitamin D levels, and exposure to common viruses that are out there, and every decade it's a different virus. This is an interesting little map, and so this is looking at whipworm and where whipworm is more common and where you see MS at. And there's an inverse correlation. So parts of the world where you see less whipworm, you tend to see more MS, and vice versa. Could be complete coincidence, could mean nothing whatsoever. But there is at least a group of people out there that has asked the question, is there an immune effect that may actually be beneficial in terms of protecting you from autoimmune conditions like MS by having certain parasitic infections? Now, I'm going to step back for a second. So this kind of leads us to something called the hygiene hypothesis. Randy mentioned that one of the ways that we could end MS is by getting rid of rich white women. And if you look at MS has always been more common in upper socioeconomic areas. And there is some thought that maybe we're just a little too hyper on our cleanliness. That mom who boils the pacifier, sticks it in a surgical autoclave when little Jimmy drops it on the floor, maybe that's not a good thing. Maybe little Jimmy needed some dirt. And that maybe if our immune system is too highly protected and we're just not exposing it to any sort of pathogens, maybe it's more likely to turn inwards on itself towards an autoimmune disease. Don't know, but it's an interesting hypothesis. So, and that leads us then to kind of how some of the big divisions in the immune system and how the immune system works, and that'll take us back to the worm theory. So the T cells in the immune system, think of your immune system as like an army, that there are different regiments that have different jobs. And that when T cells are immature, they're called Th0 cells. They don't know what they want to be when they grow up. And they can go down a lot of different pathways. They can go down the pathway of something called Th1 or Th2. There are a lot of other subdivisions out there, but that's an important one when we think about multiple sclerosis. If normally there's kind of a balance in the immune system between Th1 and Th2, in multiple sclerosis, we think you kind of live here. Too much Th1 activity, not enough Th2 activity. The worm theorists would say that parasites like the whipworm are mainly handled by the Th2 pathways, whereas viruses that maybe we're more commonly exposed to in temperate climates like North America are more handled by the Th1 pathways. So maybe if you're genetically predestined to have an overactive immune system, and now you're exposing your immune system to virus, you drive the immune system towards that Th1 pathway. Whereas if you maybe had some sort of parasitic exposure, you're driving it towards that other pathway. Well, we don't want to give you a tapeworm or give you some sort of horrible parasitic infection. So what the worm theorists are trying to do is fool your immune system into thinking that you had some sort of parasitic infection to get that Th2 response, but not actually give you the infection. And so they're using inactivated whipworm eggs, a lot of different sort of ways that they're going about that. I know University of Wisconsin, there are a couple of centers in Europe that are looking at this. Sounds crazy, but I think it bears at least watching, and who knows what it leads to in terms of other research. Maybe trying to, again, get that custom tailored treatment to the individual.
It's been very effective for Crohn's.
So there's Crohn's literature. I know at ECTRIMS, the European Committee on Treatment and Research, not this past year, but the year before that, there was an interesting poster where they presented, I think they were from France, 2 individuals who had tapeworms, real honest-to-goodness tapeworm infections, and had multiple sclerosis. And their MS was doing okay, and when they took their tapeworm treatment and killed their tapeworm, their MS got worse. And so coincidence? Yeah, who knows? And I'm going to finish up before we throw it open to Q&A, and Randy touched on this just a little bit. Just when we get comfortable with all of our names and how we subcategorize MS, things are changing. And I think this is a move in the right direction to try to let us be a little bit more precise when we describe multiple sclerosis. But you're going to see some of these new sort of terms coming out, trying to not only just use the word progressive or relapsing, but also say, okay, if you're relapsing, is it active? Meaning, are you having relapses? Are you having new lesions on MRI, or are you not? If you have progressive MS, are you progressing, or are you not? And again, realizing that there's a gray area, that you don't magically leap from relapsing to progressive overnight. And we want to be judicious in the labels that we put on people, because unfortunately, words matter. And sometimes that progressive label that we put on someone may have just given a third-party payer, an insurance company, the green light to deny treatment. So again, one of the things I remember Randy saying years ago is we're cautious about the P word in their clinic, about labeling people as having a progressive form of multiple sclerosis. One of the other things that this should help out with, and I will guarantee you someone in this room has had this experience. Someone goes in for a checkup with your neurologist, and you have an updated MRI, and the MRI looks stable. No new lesions, no active inflammation, and you say, you know what, that's great, but I don't feel so stable. I'm getting worse. And we know that that can happen, that you can have progression without new lesions. In fact, that's probably the norm as in people who've had MS for a few years. And so I think this new sort of nomenclature will help sort of at least recognize that is a common occurrence. And with that, I am going to stop. And I debated, but I did want again to say that Sam is really enjoyed working with you guys, and this is the first cruise we've done in a while without him. But he would have been 15 on Friday, and again I think he would have made a great doctor. He was actually leaning towards being a veterinarian. He said veterinarians were way smarter than neurologists. So, thank you guys.